progress.
So there you are audible. You are not audible.
Okay. Okay, so welcome to ADC webinars 2022. This is 152nd online session and 7th webinar to be presented by Dr. Ankit Arora, Simplified Clinical Protocol for Third Molar Surgery. I take immense pleasure to welcome today's guest speaker, Dr. Ankit Arora. Dr. Ankit Arora is consultant oral and maxillofacial surgeon in Delhi, runs his practice since 11 years. To his credit, he has done his junior residency and senior residency from prestigious All India Institute of Medical Sciences, New Delhi. His field of interests are impactions, different types of dental implants, orthodontic surgeries, corrective jaw surgery, and TMJ surgeries procedures. Presently, he is a startup by name of My Dental, which aims to digitalize dentists and their practice. More on My Dental will be at the end of the webinar. He will be explaining more about My Dental, and you all also can join his initiative. So I welcome my beloved friend as well as a very good supporter. He has supported me and my academy a lot. I thank you so much for him, and I welcome you, sir. It's very nice to have you on this platform for the first time. Wish you all the best. Thank you, sir.
Thank you, Sadiq, and you are doing a great job by helping colleague dentists because there is a proverb: if you help by one, you are helping the nation. Okay, just let me enable the screen sharing. I'm unable to share the screen.
So now there are 20 plus people, and very soon there will be more people will be joining. If any disturbance is there, I'll try to mute as soon as possible. You can continue without stop. Now I have shared the screen with you.
Okay. Is my screen visible? Myself, Dr. Ankit Arora. I am oral and maxillofacial surgeon from AIIMS, New Delhi, and I have been invited upon by Dr. Sudhir on behalf of ADC to give a clinical lecture on third molar surgery. So we'll stick to the topic, basically only clinical stuff, so that you guys can learn one thing or the other and can help you in clinical practice. Okay? This lecture is dedicated to my alma mater, where I have learned basic acumen of treating the patient and all other surgical stuff, and I'll be inducted to this for the rest of my life. There is no conflict of interest. I have nothing to declare, and it is not a commercial webinar where I would be promoting other stuff that you should buy this or you need to attach to that affiliation party. It's nothing like that. It is basically a educational webinar where I'll be teaching my experience, or rather than teaching, I'll be sharing my experience with the third molar surgery over the last 11-12 years. So basically, let's start. Impacted teeth, ये 90% people में पाया जाता है Indian patients में, और at least 33% people होते हैं जिनका one impacted teeth होता ही होता है. Mostly impacted teeth are those which are unable to come out in the oral cavity, as you all know. Okay, so basically impacted teeth, when it is inside the bone, you can call it as embedded teeth or impacted teeth. If at all the teeth do not have any PDL and it is attached to the bone only, it would be known as ankylosed teeth. Okay, So for removing that, you need to understand some biology, some physiology, some I would say skill, surgical skill, which we will be doing today. And uh, let's start. So the content I have been told by Dr. Sudhir that we need to be very much specific to the surgical skill so that we can add one, I would say, skill in the harmony of yours so that it will help you in treating your patient. So the content of today's webinar would be armamentarium and applied anatomy, right? ओके क्या क्या आर्मामेंटेरियम हमें चाहिए, क्या क्या एनाटॉमी हमको माइंड में रखनी है, अप्लाइड एनाटॉमी, इंसिजन कैसे देना है, बोन कैसे रिमूव करनी है, टूथ कैसे रिमूव करना है, लास्टली सूचर कैसे करना है, सम रिप्रेजेंटेटिव केसेस दैट आई हैव I would say assembled for a better understanding of yours. We'll be learning them with the help of photos, with the and also with the help of videos. In case someone has any doubt, any query, you can write it down on a, I would say, and you can ask me after the end of the webinar. So the armamentarium would be simple PMT set, scalpel with a blade, okay, periosteal elevator, Austin retractor, Minnesota retractor, or the Sheldon retractor, whatever you are comfortable with, okay. Elevators, forceps, and hemostat needle holder. You can basically you need to have these armamentarium before you can approach upon a third molar surgery. Basically in today's webinar also I'll not be dealing with the upper one. I'll basically be dealing with the I would say the lower one. That third molar surgery, the lower one, is in itself is a very huge topic, I would say. So I will be dealing only with the clinical aspect of the lower third molar surgery. Okay, so basically coming to the surgical anatomy, we all know we all are afraid of inferior alveolar nerve, aren't we? Okay, so this is the nerve that goes just below the root apices of the third molar. Okay, so we need to take care of inferior alveolar nerve, right? We need to take care of the inferior alveolar nerve, right? So what are the other nerve which we need to take care of? The buccal nerve, the inferior alveolar nerve, okay, the mylohyoid nerve, and the most importantly is the lingual nerve. So these are the things which we need to, I would say, which we need to be very much specifically considerate about when we do our surgery. So these are the basic applied anatomy. We will understand the concepts of, I would say, where these nerve will be encountered in real life scenario. How can you prevent it? What are the prevention or maneuvers you need to perform to avoid the surgeries? Okay. Now coming to the operative procedure. Operative procedure is basically you need to paint and drape on skin betadine, inside the mouth chlorhex, as simple as that. बाहर betadine लगाना है 5%, अंदर की तरफ chlorhexidine 0.2% रखना है. Okay. So the chlorhexidine gluconate 0.2% for rinsing oral cavity. So okay. Now before we jump to the surgical aspect of the third molar, what we need to understand is there is a Grodin method where we can assimilate what is the type of impaction. Is it a distangular, is it a mesioangular, is it a vertical impaction, and how it is going to help us in treating our patient clinically, we will see in the coming slides. The easiest method is to understand that, if at all, I would say, what you need to understand is you need to see the gap of the interdental bone between 6 and 7. If this is 6, this is 7, and the gap between 7 and 8. If the gap between 7 and 8 is greater than the gap between 6 and 7, it is mesioangular. Okay. If it is more or less equal, you can call it as a vertical impaction. And if it is vice versa, that is the distance between 6 and 7 interdental bone level, or the distal or mesial margin of the 6 and 7 is more than the 7 and 8, then it would be distangular. Okay, horizontal, I don't think I need to explain it to you. It will lie perpendicular to the distal surface of 7. So that would be, so in this way you can easily see in the IOPA or OPG and you can assimilate that it is a mesangular or distangular. Forget about wall line or Warfare assessment or other Paul and Gregory classification. This is the basic funda. This is the basic classification on which you can look upon the IOP or the OPG, and you can assimilate the type of impaction the tooth presents. Now you can understand, you can easily see it there that this is an OPG. You can see the gap between 6 and 7 and 7 and 8. You can easily calculate that, okay, this is the mesangular impaction. Okay, now you can easily see that. Okay, now coming upon the clinical presentation, either you can go or tell the patient to undergo IOPA, more I would say suitable, more practical way of having the impacted tooth assimilation, having the impacted tooth diagnosed with the help of the IOPA. But if at all you cannot ascertain the inferior alveolar nerve or the root apices of the impacted teeth, it is always advisable to go for an advanced investigation, be it orthopentamogram or a CBCT scan. Okay, so if at all you can see it in IOPA, nothing like it. No one wants to send their patient for a higher investigation, but if at all you feel like that having one more investigation will help me preventing one more surgery or a complicated or to avoid complication, we should always go for a one more investigation. Okay, let us go to the flap reflection. But before we go for the flap reflection, we need to deposit local anesthesia. For depositing local anesthesia, I always advise, and I'm of the opinion, and I always follow that you should give ample amount of local anesthesia when you perform surgeries, specifically on a mesodermal tissue like bone. That is, if you are performing root canal that is on the ectodermal tissue like enamel and dentine and pulp, you can give articaine or local anesthesia in the measurement of 2 to 3 ml. But if you are giving it for oral surgery procedure where you are dealing with the gums, bone, and all other structure, you need to give minimum 5 to 6 ml local anesthesia. For that, you need to have a 5 ml syringe. Give 2 ml for inferior alveolar nerve, 1 ml for lingual nerve, 1 ml for buccal nerve, and 1 ml for the infiltration in the buccal side of the impacted teeth. So this is how I basically follow. I basically take 5 to 6 ml local anesthesia, and this is the order which we basically follow. And I wait specifically for 8 to 10 minutes. That helps me getting two basic purposes. First, it completely anesthetizes that area. Obviously, we do not start before the anesthesia take its own complete effect. And second, for hemostasis, the amount of local anesthesia we give 1 to 2 ml, it basically allow to have a better cleaning, better clean surgery, which you will be seeing in the coming slides also. Okay, so this simple maneuver of giving ample amount of local anesthesia helped me getting a good surgical flap, which lays the foundation of a good surgery. Okay, so let us focus on the flap reflection. It is a you need to have a good flap. We'll be seeing in this in the coming video also. You need to have a good and adequate exposure, and you should avoid buttonholing. Means it need not to be like that. You are opening the flap and basically you need to have a proper bony exposure. Understanding of the anatomy in that region. Okay, understanding, you need to understand that anatomy basically, and you need to retract it adequately for self-retaining retractor. Basically, that Minnesota retractor or other retractors, additional retractor, you need to have a proper flap. What are the blades? You can write it down. Basically, the blades that in dentistry, they are basically 3 number, 11, 12, and 15. The 15A or 15B number blade is basically used in third molar surgery. This is a mounted scalpel blades on scalpel handle. You can use it, or if you want, you can use a disposable handle also with a graduated marking as a scale. But make sure that disposable handle they need to be discarded after surgery. We should not be much more meager, or I would say conuse of saving that disposable, because obviously the instrument, they need to be of a metal structure. Anything other than the metal should be discarded, be it suction tape, be it tray, be it needle, whatever is plastic need to be discarded promptly after every surgical procedure. Okay, and at the same point of time, you need to make sure whenever you are using your incision, always use a proper new blade for a new flap. Obviously, you need to have a new blade for every new patient. I'm saying make it a step higher. That is, you need to have a one more blade for a new flap also. Okay, for one blade for new flap. Now, when you elevate it, the clinical tips I have specifically write it down that you need to have periostal elevator, which you also known as MOLTS number 9 periostal elevator, and try to strike it from the interdental papilla from the underlying bone. That is the papilla from the region between 7 and 8. That is the second molar and the third molar. Okay, that is.
તપેલુંનો સવાલ નથી પહેલી વાર આવી ત્યારે ગરમ
And okay, and regarding the push stroke, that is the price stroke, and the push stroke is the opposite side of the elevator, which is more broader, and you can use it and push it, and the attached gingiva and the alveolar mucosa are reflected to the desired extent, are reflected. Okay, this is how full stroke would be there, and can sometimes obviously shed the periosteum. Okay, this is how the retractor is used. Basically, 3 retractors are there: Selden, Austin, and Minnesota. I basically prefer Austin retractor, and in that there are also three type of retractor. The one with the margins free and the gap between the teeth, so that it allows the tissue to go in between, and the Minnesota retractor. Okay, and the Minnesota retractor. So right. So this is how it looks like. You can see here. Okay. Okay, now you can see the incision. It goes from 7 to 8. Okay, 7 to 8, around 2 centimeter down. Okay, in a oblique buccal manner, and then you release your flap from and in around the tooth, the 8 region, and you go distally, and you go like this. Okay, and you go distally. This is how it would be. This is the lingual margin. You do not go there. Now we can see this is the lingual margin where our periostal elevator is there. This is our the second periostal elevator, which demarcate the distal boundary, and you can see the Austin retractor with a dedicated gap, which allow the tissue to go in between. Okay, this is how it looks like. Let us see another case. Okay, this is how it looks like, the same case, which you can see it here. We have given the ample amount of local anesthesia, which is also appreciable in the tissues, which are more or less vasodilated. You give an incision like this and go for the incision in this manner, and more I would say to the distal buccal margin, right? Let us see one video where we have reflected the flap in the same manner, and we will see it, right? This is the anterior. Okay. My video, this video is visible. Can someone write?
Yes, sir. Visible.
This is the anterior limb of the ward incision. As you can see here, starting from the interdental papilla between 7 and 8. And this is how it is proceeding. And it is approx 3 centimeter in length, 2.5. And this is the intermediate limb going in between the 8 region. And this is the posterior limb, which is going laterally, as you can see here. And I have retracted temporalis fiber. And you can see here, this is the external oblique ridge, and this is the masseter muscle attachment, and this is the area where the maximum swelling occurs after extraction. And you can see here, now an incision should be made for the third one. Okay, so this is how we give up basically incision. Okay, and just give me 1 minute to share the PPT. Okay. Okay, so this is how it looks like, and this is the incision which we have done, which we have taken from the same patient, and this is how the anterior limb look like. Okay, this is the anterior limb incision. The middle one is the intermediate limb, and the other one that goes on the distobuccal margin is the terminal incision, which you basically see, and we have to make sure that in between the flap our mandibular third molar lies. In between a flap our third molar lies. Okay, so let us come to the second half of our surgical procedure. That is, we have given on, I would say, in fact, the third part, we have given the local anesthesia. We have waited for 10 minutes. And after that, we have given the incision in the form of the anterior incision or the intermediate incision or the, I would say, the distobuccal terminal incision. Now, let us come to the bone cutting part. Before we start the bone cutting part, we need to answer ourselves, is it really required? Why are we removing it? How are we going to do it? And how much we need to do it? Okay, let us see, let us understand that how much bone need to be removed. I would say the most practical answer to the question would be bone should be removed till we reach below the height of the contour. Okay, now you can see it here. Now you can see if it is an horizontal impaction, you need to go till the height of the contour or its greatest circumference where we can apply the elevator. I have received a question from one of the participants that where we need to apply the elevator. We will see the video also regarding the same. But for your practical purpose, you need to make sure you need to apply elevator below the tooth. As simple as that. Below the tooth. If at all it is a mesoangular impaction. Okay. If it is a horizontal impaction, you need to go below the greatest circumference. And whenever you feel like more bone need to be removed, you can shift that bone removal to a tooth sectioning. Okay, now you can see it here in the second and third diagram. Whenever you feel like that more amount of bone need to be sacrificed, you can divide the tooth into two halves. Okay, either in this manner, or you can divide the tooth into three halves. Okay, the basically the crown part and the root part. Okay, extensive bone removal can be removed. One more question I was asking, I was being asked that how do we divide the tooth? How will ascertain that tooth need to be divided, root need to be divided? So basically we will be seeing it in the coming slides. Okay, now you can see it here. This is how it looks like. We removed the bone margin. Basically, bone margin is removed from the distal of the second molar to the distal lingual margin of the of the wisdom teeth, right? So basically, from I would mark I would rather mark it so that you can see it here from here to here. I don't think you are able to see it. Now you can see it, right? You'll be able to see it now, right? Okay. So basically, this bone need to be removed. Okay, from distal of 7 to the distal lingual margin of 8. So this is and how much depth? I would say you use 703 bar, that is of 0.7 mm width and I would say 1 centimeter 1 centimeter length. Okay, 1 centimeter length. Okay, 8 mm length. So basically you need to go 1 bar depth, 1 bar width of 703 bar. You will never be at, I would say, fault. Okay, maybe it might be more required in say 10-12% of the cases, but in 80-85% cases the one bar depth and 1 bar width of 703 bar would suffice the process. Okay, would be sufficient. So this is how it looks like. The another case where you can see it here. In fact, the blood pooling in itself is an indicator of how you are going to do the buccal cutting and where the blood pool will happen. Okay, this is how it looks like. This is how I would say the another case. You can see it here, the distobuccal margin started from the distobuccal margin of the second molar to the distal lingual margin of the, I would say, of the wisdom teeth. You can see from the another half, you can see it here. Though the tooth number 7 was also sacrificed because of the root stump area. Now you can see it here from the distobuccal margin of this 7 to the distal lingual margin where our periostal elevator is there. And the moment you free it up, I would say 90% of the mesoangular tooth will come out easily, unless and until it is ankylosed or the root is in the other position or the number of roots are more. So basically, in Indian scenario, mostly wisdom teeth have 2 roots. In seldom cases, it has 3 or 4. But in most of the Indian cases, we are privileged to have only 2 roots, which is easy to get. Okay, so let us see. I would say one more video regarding how we are going to do the bone. I would say guttering, so that you can see that procedure, right? This is the bone guttering which we have done. It started from the mesobuccal end of the impacted third molar, which is done with the help of 703 straight fissure attached with a straight handpiece with a speed of 40,000 RPM. And what we have done is we have gutted till 1 to 2 mm below the CEJ of the tooth that has to be removed. As you can see here, my finger will go about 1 mm below the CEJ. And the moment we start and progress to the distal end, it goes till the most distal point of the distal lingual bone of the third molar. So we are here with our impacted third molar, which is lying in an impacted bone, with the help of which we have removed the bone, and this is the fulcrum point where we have to remove the tooth. Okay. So when we have removed the bone, now we know that okay, we are easy to go with our impaction, and we can remove it. Now either you can go for tooth sectioning or delivery of the tooth or removal of the tooth, right? So basically, if at all you will see in horizontal impaction, you need to divide the tooth, or you need to deliver the tooth in the cases of mesoangular impaction. So the question that arises here is, where do we need to section the tooth, or where do we need to make an attempt to remove the tooth? So basically, in cases of tooth sectioning, there are some indication. Before you go for tooth sectioning, or I would say removal of tooth, it should be very much clear in your people mind that I would say that that this tooth need to be sectioned. Okay, the indication of that are is the tooth locked, or unfavorable root pattern, or to protect important structures like nerve. Let us see it again in a clinical, I would say, acumen, to improve our clinical acumen. Obviously, it has some advantages. Field of operation is small. Obviously, you need not to go for removal of the bone and go ahead. Okay. Less post-operative swelling and trismus would be there. Okay, less post-operative swelling and trismus, and bone removal is considerably reduced. Okay, bone removal basically you need not to go for more removal of the bone. There's a saying in surgical practice that bone belongs to the patient and tooth belongs to the surgeon. Is it right or wrong? No. Okay. It basically says is, if you play more with the bone, patient will be hurt more. The tooth belongs to the surgeon. Basically, you can play as much as you can with the tooth. Okay. It is not going to harm patient. Obviously, it needs to be taken out either in 1 piece or 2 piece. It's up to you. But if at all it can save the bone, nothing like it. Okay. Operating time shortened, I would rather disagree with it. It will increase the operating time. No damage to adjacent tooth. Okay. Obviously, if you divide it properly, the cap, the restoration, the decay margin, or the cuspal inclination of the second molar, it rather tend to be decreased, not harmed, if we divide the tooth. And risk of jaw fracture is reduced. Obviously, when you take a fulcrum in undivided, ankylosed, or undivided impacted teeth, it further put pressure on the jaw line downward, or the TM joint upward. So in such scenario, it is always better to divide the tooth. Okay, but how? Let us see it. Let us see it in coming slides. Now you can see it. What is the criteria to decide section of the tooth? Okay, it's simple. If you take a line and you draw from the mesolingual cusp to the distal root. Now you can see it here, a blue line, right? a blue line here. You can see it here, right? And then you can okay. Now you can basically right. Okay, now so basically what happened is you draw a blue line, right? And you draw a arc, like an arc, after taking its half of the radius. And when you draw an half of the radius, if at all it touches the cusp tip of the second molar, it touches the cusp tip of the second molar, you need to section the tooth. You need to section the tooth. Okay, so basically, in that sense, we say that the tooth is locked. It will not come out unless and until you will remove the underlying and the overlying bone and section it properly. Now sectioning might differ. Let us see and understand it further. Where you need to divide the crown or 7 into 2 parts or in 3 parts. Let us see. Okay. Okay. Now you can see there. This is the mesoangular teeth. Though it also be it can also I would say be removed in cases of direct I would say removal of the bone. But now you can see in simple OPG view that these roots might be there in the inferior alveolar nerve. Though OPG is a 2D representation of the same, but at the same point of time we need to take proper care, proper precautions, proper measures, proper maneuver to avoid the injury to the underlying inferior alveolar nerve. Right? And this is the distangular impaction. You can see it here. The distance between the 6 and 7, I would say 6 and 7 incidental bone area, or the 7 and 8. It basically see that this is a distangular impaction. You elevate the tooth, divide the bone completely from the, I would say, from the distobuccal margin of the 7 to the lingual margin, distal lingual margin of the 8. After that, when you see it here, when you try to pluck it out, it don't come out. Then you need to section it like this and like this. Okay, like this and like this. So basically, these are the maneuver technique for removing the or the sectioning of the tooth of the mesoangular and the distangular. Right. Now let us further divide and see how are we going to section the roots of the wisdom teeth in and around the, I would say, in and around the wisdom teeth. Okay, in and around the wisdom teeth. So basically, I would say I follow the principle. If at all the distance between two roots, is greater than 2 to 3 mm at the apical margin, right? At the apical margin, you can divide it. It's basically a purpose. It's basically your call that how do you want to divide it and how do you want to proceed it. If at all it comes out, well and good. But if you feel like that it needs to be properly sectioned, then this is the criteria which I follow, which I read in the article, that at the apical margin, its distance should be either 3 mm or more. Okay, you can remove the bone, which you have already seen it like this, and you divide the tooth like this. You remove it. The one part and the other part like this. If at all it is fused or bulbous, you can consider this as an in toto single structure. Remove the bone from the distobuccal margin to the mesolingual to the distal lingual margin and try to pop it out. If at all you feel like it is interlocking, you section it up. Otherwise, you can remove it in one half. But root section in this scenario need not to be removed because we have already seen it here. Now there is another one scenario which you can see it here. If at all you feel like, then if a interradicular distance is 2 mm or 3 mm at the region, you can divide it as per your convenience. If at all it comes out in the one section, well and good. Otherwise, you can divide the roots also. It's up to you. So now you can understand the principle where you need to go for a where you need to basically go for a tooth sectioning, or where you have to follow the root sectioning also. Okay, root sectioning also. Mostly I feel that mesoangular impaction in Indian population, they basically come in 80-85% of the cases by simply removing the bone from the distal rectal margin to the distal margin of the 8%. Now coming to the deep vertical impactions. Deep vertical impaction, which you can see it here. If at all you wanted, you can remove it. You can remove the bone distal lingual margin, as we have already discussed. You can divide it the tooth by using 703 straight fissure burr. You can remove the crown and the distal root also. And after that, when you find the gap at the distal margin, you can use your basic tooth length procedure to deliver the tooth. We will also be seeing the video for the same. Where do we need to find a fulcrum? Where do you I would say find a way to remove the tooth? Okay. Now this is an horizontal impaction. You denude the root as I have discussed it multiple times from distal buccal to the distal lingual margin, and now you can divide the section into perpendicular manner. Okay, remove the crown first, and the moment you find the crown first, you just denude the root over the distal and the mesial root. Put a small I would say ditch in the distal root, and use your Winter's crossbar or a crier elevator to elevate the mesial and the distal root. This is how it is done. And the moment you do it, you prevent injury. You prevent injury to the second molar and the inferior alveolar, to the inferior alveolar. Okay, and okay, this is how now how do you deliver the section tooth from the socket? Okay, so what are the basic principles where you section the tooth, which you have already seen? Basically, you can use the straight elevators. You can use your Warwick gem, which is the most commonly used, or you can use the straight or curved elevators as per your convenience. But make sure that its beak is not sharp or it's not conical, because underlying it would be the I would say inferior nerve, or on the lingual side it would be lingual nerve. So basically make sure that it has a broad end. Okay, it has a broad end, and it is a crier elevator. You can use a crier elevator or crossbar, it's up to you. Basically make sure of these three things. You should not apply excessive force to prevent injury to the underlying soft tissue, which is on the ductal side and the lingual side. Okay, adjacent tooth, that is the 7 and bone, or as well as the TM joint. Okay, and inferior alveolar canal and the lingual nerve. Inferior alveolar canal is just beneath the third molar region, and the lingual nerve, which is in the lingual flap. How we can prevent it, we'll be seeing in the coming slides. Okay, this is how the tooth is divided. Okay, this is the mesial angular tooth. There the crown part is divided and the root part is divided, and the photograph is being taken. And other thing which you need to make sure, many a time what happens is, many a time you can see it here also, when you deliver the tooth, the lingual soft tissue is being attached to the tooth. Okay, lingual soft tissue. This is very much common. So that let me change the color from red to black. Okay, red to black. No, I would say no. Yeah. Yes. Now it is visible. Now you can see it here that it is attached to the tooth. So need not to pull out the crown inadvertently or in a strong fasting pull motion. Make sure when you deliver the tooth, make sure when you deliver the socket or tooth from the socket, there is nothing attached. There is nothing attached to the root. Okay, there is nothing attached to the root or crown of the third molar. You have to free it up, and simply when you free it up, you can use your blade. Okay, you can see it here when we elevate it. You can still see it here. The attachment of the tissue from the tooth structure. So you can use it your blade, or you can use it a elevator, periosteal elevator to free it up. Okay, when you free it up, now still you can see it here. When we are pulling it here, we still having distant torsion from the distal flap tissue. So basically you need to free it up before you pull it out. If at all, if you could have pulled it out, there would be more injury to the surrounding tissue, which might result into the possible injury to the lingual nerve. I won't say it would, but there are higher chances, if at all, you do not pay much attention to the finer details that are involved in the surgical procedure. Okay, you can see it here when we elevate it, and this is how it is delivered. Okay, now this is the same, I would say, distal socket, same case which we were discussing. This is how it looks like. We'll be seeing the video of the same case where you have removed the bone margin from the distal buccal to the distal lingual margin, and this is how the crown is removed. Before, I would say, dividing the root half, you should always try to remove tooth in one I would say one piece, okay, in total. Basically it avoid the lingual injury, but if at all it is, as I have already discussed, it is in the near proximity to the lingual nerve or the inferior alveolar nerve, you should always try to remove it in proper sections. Okay, you should always try to remove it in proper section. This is how it goes. Let us see one more video so that we are more sure of what we are up to, what we have done till now. Okay.
Now we are putting this.
Okay, let's start.
Now we are putting this coupland elevator, straight coupland elevator in the fulcrum. What fulcrum means is the deepest point through the buccal cutting which we have created, and we'll go there. And the moment we fix it, we'll apply the straight elevator in a perpendicular motion.
I'll repeat. So what is basically the fulcrum is? You are just going beneath the tooth in the buccal guttering area which you have created, and you just go beneath the tooth in a perpendicular motion. Okay, in a perpendicular motion. Okay, and you need to apply firm digital pressure against the tooth. You need not to go into the lingual pouch. I'll repeat, you need not to go into the lingual pouch, but against the socket, against the tooth, you need to put your pressure, right?
Like this, we'll put our thumb between 7 and 8. So as
put a digital pressure on 7 and 8 while you are luxating the third molar. It should not be like that. You are putting a pressure and ultimately you luxate the 7. Irrespective of fulcrum, you ultimately remove the 7. Okay. So you need to be very much sure that you are luxating the right tooth at the right place in a right manner. Okay. So you need to put your firm digital pressure on 7 and 8 so that your I would say tactile perception will tell, okay, yes, I am feeling the perception on the 7 rather than on 8. You need to change your position or you need to gutter it more. You need to remove bone.
know that 7 is not getting moved or accidentally or hydrogenically. And we'll tell the patient to close the mouth slowly. Okay. Now you people can see. Yes. Now I'll apply my forces here, and you can see the elevator forces, and this is how it is done. You can see the movement of the tooth. You can see the tooth movement. Yes. Slowly and gently, and then we'll apply the forces again between 7 and 8, and we'll try to go as deep as possible, not at 1 to 2 mm below the CJ. Now the moment it started moving, we have to keep moving the coupland elevator as deep as possible. Before that, at the initial point, it was like this.
So the key takeaway point is, what you need to understand is, when you remove the third molar, what you need to that if at all you are applying the fulcrum and tooth, I would say has been elevated to 1 to 2 mm above from its socket or from its pre-existing original position. So what you need to take advantage of that position is, you need to put your fulcrum position slightly deeper. Okay, slightly deeper, and you need to dig more with that I would say elevator, or you can change the position with a broad base. अगर हल्का सा टूथ बाहर आ गया है तो उसी पोजीशन पे हमें फुलक्रम नहीं लेना, हम उससे थोड़ा नीचे और जा सकते हैं. Okay, that is what the basically point is. You can see it again.
And we'll try to go as deep as possible, not at 1 to 2 mm below the CJ. Now the moment it started moving, we have to keep moving the coupland elevator as deep as possible. Before that, at the initial point, it was like this. I'll explain it again. You can see it here. This is the point where it was initially, and the moment it started moving, I have started my coupland elevator as deep as possible, and now I'll start moving it like this, and this is how the tooth will move out from the socket. And the moment,
okay, this is how the tooth is delivered. This was the undivided root, so it was delivered. The moment, most of the time, practical I would say scenarios, when you elevate it, you would find that the disto buccal margin distobuccal margin of the I would say 8 will be hindering, because obviously most of the time it delivers in that manner, except for the disto-angular tooth. So you need to gutter it more. You need to remove the distobuccal margin more of the wisdom teeth, right? So this is an, I would say, hit and trial permutation combination of and how you would win the tooth. Okay, how would you win the race? So the moment you find it, don't try to put it pressure. As you have seen in this video, I would say 90-95% of the cases would be removed if you properly section the tooth, properly remove the bone. And there's a saying in a book called Peterson: whenever you are removing the tooth, the wisdom tooth, it should be like that you are plucking a flower in the garden. The whole proximity of the tooth of the bone should be contoured in such a way, either removed or sectioned, that when you pluck it out, it should come out like a piece of flour. Okay. Now what we are up to? We have now what we have done is we have removed the tooth, and now we are at the closure of the wound. Okay, closure of the wound. And before the closure of the wound, we need to reposition the flap by tweezer or whatever the tissue holding forceps you have. You can try to put it on the lingual margin. Yes, I am having a proper distobuccal margin, proper margin, or you can give your incision a little bit more so that you have a primary closure there. Okay. So basic purpose is to suture it up. Okay. Let us see. We are going to do it. We also have a proper video there. What need to be seen there. Okay. So before you close it, you need to prepare the wound for closure. I'll repeat. You need not to close it like this. You need to properly prepare the wound so that the clot that is inside the socket or beneath the tissue need to properly be there. Only then it would be properly prepared, right? You need to irrigate it with a betadine solution. You need to irrigate it with proper saline solution. If you find loose stacks of mucosa granulation tissue, you need to remove it. If you find a little piece of say root teeth, crown, you need to irrigate it. But before closure, you need to take a proper IOPR. Okay, there is a specific process. You need to take a proper IOPR so that you know nothing is left behind. Okay, nothing is left behind. You need to take a proper IOPR. Okay, so I would say, and you can use the large pieces of socket and interradicular septum. Right now, how you are going to debride the wound and closure? You need to thoroughly debride the socket by periapical curettage. Okay, you need to clean it up with a periapical curettage. You can smooth the sharp bony margin by bone file or the round burrs which we are discussing, or you can use the straight fissure burr also. Thorough irrigation of the socket you can use. Okay, thorough irrigation of the socket. If at all it is there, you can use it, right? You can use it. And initial wound closure is achieved by the first suture should be just distal to second molar. Okay, why the second molar? See, when you will remove the 8, most of the time the 7 would require the root canal procedure, because obviously in an Indian patient they come on a symptomatic basis. जब दर्द होगा तभी आएंगे, उससे पहले most of the time नहीं आते. ठीक है, so mostly 7 को आपको suture देना पड़ेगा. Okay, 7 को आपको suture देना पड़ेगा, right? And so this is how properly just daddy. And if at all it is a pocket, I would say pocket is there, then you need to properly make sure that there is no pocket in and around 7. Otherwise after 15 days or a month, डॉक्टर साहब आपने सर्जरी तो बहुत अच्छी करी थी लेकिन खाना अभी भी फंसता है और पिछले 2 साल से फंस ही रहा है. Okay, because we didn't pay much attention to the detail कि suture भी उतना important है जितना आपका third molar निकालना है. Okay, posterior relieving incision आपको अच्छे से देना है. Interdental area mesial to second molar, और 3 से 4 suture are I would say 3 to 4 suture are usually sufficient. Let us see video of that also so that you guys can understand what I am up to, and you can obviously understand that. Okay. Okay, needle holder, basically it should have a groove and cross hatching and a scissor cutting blade. You can use it, and the jaws which you can use it. Basically long needle is, I would say, more preferable in cases of a long needle is more preferable. Okay, so that you can go there, you can see it there, right? You can see it there, right? And what are the needle holder clinical tips? Obviously, it is available in many style and sizes. I would say वो जो जहां पर भी आप फॉरेंडल इंफेक्शन कर रहे हैं वहां पर हमेशा लार्जर निडल यूज करिए. ओके, लार्जर निडल यूज करिए. द ओनली थिंग इज यू नीड टू मेक श्योर दैट योर निडल in the needle holder should be strong enough, and it is at the point of 2/3 junction and 1/3 junction. I would say if we'll have another lecture or two, we can discuss regarding the I would say regarding the suturing part. Okay, there are needle holder and hemostat in many clinics. I see they feel or they confuse themselves with the hemostat rather than the needle holder. Okay, needle holder basically looks similar, but jaws are thicker and shorter. वो छोटा होता है हेमोस्टेट. ओके, हेमोस्टेट छोटा होता है और जो needle holder होता है वो लंबा होता है, उसमें रैचेट होती है आइज के. ओके, now after that before you close it you need to have a bone file. कहीं पर कोई स्पिक्यूल चुभ रहा है, कहीं पर कोई पोर्शन लग रहा है, you need to remove it. For final smoothing of the bone before you suture the flap back into position, we need to make sure that वो flap कहीं पर नहीं लग रहा है. If at all आज के दिन में अगर कहीं पे bone file नहीं है, need not to worry, we have good birds available in the market. But if at all you are using bone file, you need to pull it. Do not go into the lingual pouch. I am repeating again and again. Just go from the lingual pouch to the buccal margin, right? To the buccal margin. Avoid cross filling or pushing the bone file, because this will result into the burnishing and the crushing of the bone. Carefully cleanse the instrument by wiping out the groove and by the I would say by the sponge. And by failure to do this, dust or chips may easily remain in the bone. So basically, you need to clean your instrument. Obviously, it's very costly. And at the same point of time you need to clean the socket also, because of the I would say burnishing, the bony chips, it might tends to go into the socket. Or you can use it, the bony ronger. Basically it happens in the upper third molar impactions where the tuberosity bone is basically there. You can use it with a multiple bite. Okay, that is what is known as ronger forceps. Ronger is basically the rat analogy has been taken. It takes a smaller bite. Never ever take a bigger bite. ज्यादा बोन एक बार में नहीं निकालने, छोटी छोटी करके 2-3 बार में बोन निकाल सकते हैं. ओके, छोटे बोन्स वगैरह आप निकाल सकते हैं. A constant cleansing of the blade is necessary. You always clean the blade, or do not remove your deciduous tooth. Do not remove your root pieces. Do not remove your tissue with the help of a ronger forceps. Once उसका पूरा बीक अगर लॉक हो गया, सब चीजें खराब हो गई, तो ultimately you need to buy a near ronger. Okay, this is how it looks like. We'll again see the video so that you guys are familiar with the photogenic memory as well as the videographic memory also. So that, okay, this is how it looks like, the distal margin tissue. Okay, let us see our video again, right?
These are the
Okay, this is the same patient, same videograph, same photo.
These are the 4 sutures which I have given, as you can see here. 1, 2, 3, and 4, just distal to the second molar. I prefer not to give the incision on the anterior limb so as to allow the seroma to flow through the vestibule, which helps through the cleansing, natural cleansing, as well as the gravity force. And you can see it here. If I push along the incision from the posterior limb to the anterior, you can see the blood that will seep out. You can see here that will seep out, and this will also allow to help in reduction of the swelling that happens in post-operatively. So I just avoid to give the suture in the anterior.
Basically, the purpose is I would repeat it again without voice so that you can understand it. Basically, the purpose is to give a tight, firm suture at the just beneath the second molar, right? Just beneath the second molar, so that you don't have a pocket whenever you are giving the crown, or even if you are not giving the crown, khana nahi fasega. And second is I'm leaving the you can see it here. I'm leaving the releasing incision here. I'm leaving the releasing incision as such. I'm not suturing it up because of simple 2 factor. It will allow the seroma or exudate or any lymphatic collection from the extraction side to go into the vestibule. जो भी ब्लड कलेक्शन होगा, जो भी लिम्फेटिक वेसल होगा, वो सारा का सारा कलेक्ट होके मेसेट्रिक पाउच में ना जाके जो बाहर स्वेलिंग के फॉर्म में हमें दिखता है वहां नहीं दिखेगा, बल्कि वेस्टिब्यूल में ही चला जाएगा। एज अ रिजल्ट वहां पर हमारी स्वेलिंग नहीं आएगी। अगर आप अच्छे से आप रिलीजिंग इंसिजन को छोड़ दोगे तो वो सारा का सारा लिक्विड वहीं पर ही कलेक्ट हो जाएगा। एंड एड टू दैट, if at all you can put your, I would say, steroid and the Dynapar injection into the mesenteric pouch here only. It will help you in preventing swelling to a next level. बिल्कुल भी पेशेंट ना पेन की कंप्लेन करेगा ना स्वेलिंग की पेन करेगा, क्योंकि ऑलरेडी आपने इंसिजन फ्री छोड़ दिया है। एंड सेकंड, जो भी आपकी जहां पर सर्जरी हुई है वहीं पे डायरेक्टली आप स्टेरॉइड और आई वुड से NSAIDs का इंजेक्शन देंगे, तो एज अ रिजल्ट वहां पर पेशेंट को ज्यादा फील भी नहीं होगा पेन का। Okay, obviously you have given local anesthesia, so patient don't feel, I would say, discomfort in having the surgery done. Okay, let us discuss it again. Okay, now after when we have done the suturing, let us come to the post operative part. क्या दवाई देनी है, I have already discussed. You can give it here. You can this is here. I have given the steroid part and the NSAID part. You can see the swollen part here, and this is here the releasing incision. The liquid can come out. Right now we have done one study where we have looked upon, do we really need to give antibiotics in I would say after the third molar surgery, because obviously we as a dentist, we are I would say more accustomed to give more medicine to our patient rather than if at all it is required, obviously. Okay, so what study we have done, and we have understood during my training at All India Institute of Medical Sciences, that if at all you alter the bone level for more than 20 minutes, you need to give antibiotics. In the systemic region, you can give augmentin or whatever you feel like. But if the bony surgery is less than 15 or 20 minutes, I would say you need not to give the antibiotics. Okay, so you have to be very precautious. Not because the antibiotic would cost more, but obviously because of the antibiotic resistance. And the practical examination we already have seen during the COVID era. Many medicines were not working during the COVID, because we guys are more, I would say, susceptible, more accustomed to take antibiotic without any, I would say, per reason. Okay, so we have to be very precautious, not only in surgery but also prescribing medication to our patient. Now coming to the complication. Okay, there's a saying in surgery सब कर लेते हैं, complication जो handle करता है वही better होता है. Okay, so let us handle complication one by one, कि क्या सर्जरी होती है, कैसी कॉम्प्लिकेशंस होती हैं और उसको कैसे हमने हैंडल करना है. पोस्ट ऑपरेटिव कॉम्प्लिकेशंस में ड्राई सॉकेट होता है. ओके, लेट अस डिस्कस इट. लिंगुअल नर्व विल डिस्कस इट लेटर. now coming to the dry socket first. We all know, we all have treated well. Okay, so the dry socket is basically seen in smokers, in female taking oral contraceptive. Basically pain is mostly on the third and fourth day. Okay, so you can give dressing, or you can irrigate the extraction side. You can give saline dressing, you can give urinal dressing, you can give alveolar dressing, or you can give an annual dressing. But the moment pain start, it basically take 10 to 14 days. If I would say, as per my experience, if at all you close the mesodermal tissue from the external environment, dry socket will cease to exist. मतलब अगर आप बोन को बाहर टच नहीं होने दोगे या फिर कम्युनिकेट करने नहीं दोगे, either with the help of compression, or either with the help of dressing, or either with the help of a suturing, it won't happen. Okay, bone जहां पर टच होता है बाहर environment में, वहीं dry socket होता है. Okay, so you need to cover it properly with the help of a suture. Dry socket होने के chances बहुत कम हो जाएंगे. Okay, okay. Now coming to the pain part. Pain basically it usually reaches maximum during first 12 to 14 hours post-operatively. You can use steroid, you can use ice, may be comforting, but has a little effect on size of swelling. Okay, swelling reaches maximum by the end of the second post-operative day. You can use it, and you can use the steroid part as far as comfort, and you can use the icing part. Right now coming to the bleeding. Obviously bleeding I would say is the issue. I would say is the issue of improper technique. Okay, you need to have a good surgical technique. You need to minimize trauma. You need not to put flap or surgery. avoid tearing of flaps, and basically the maximum best effect, best measure to achieve hemostasis is application of the gauze spaces over there. Okay, you can apply, or you can use other oxidized cellulose or a Surgicel. Okay, patient with acquired or congenital coagulopathy may need blood vessel replacement, but it is not at all required to learn as such. But you need to put a good pressure there. And if at all you want to see, you can use a Surgicel. It is readily available in the market. You can have it in your clinical practice. In case you feel like that there is more bleeding, you can put it there just beneath the gauze piece or a surgical part. You are good. Okay. TMJ pain is already is basically, I would say, seen, and it happens. It basically happens as you have must have noted when I was delivering the tooth in the video, that you need to allow the patient to slightly close the mouth so that it relieves the disc. It relieves the disc, and it basically, and if in case the TMJ pain is there, you need to give, I would say, more anti-inflammatory medicine in case of ibuprofen or paroxicam, or physical therapy in the form of a hot fermentation, right? Now coming to the lingual nerve injury, if in case lingual nerve injury, you feel like it might happen, or you want to prevent lingual nerve injury, we need to understand where the surgical anatomy is. Okay, I have seen cases where patient have reported to me, डॉक्टर साहब मेरा दांत तो 5 मिनट में निकल गया था, but lingual nerve नहीं, से पेन हो रहा है. And when I asked the associated dentist कि भाई ये क्या हुआ, मतलब टूथ कैसे हो गया, बोले सर मेरे को कोई प्रॉब्लम नहीं आया, टूथ निकाले में 5 मिनट में निकल गया, मैंने सूचरिंग करी थी, उसके प्रॉपर कर दिया, बंद कर दिया था, कहीं कोई ड्राई सॉकेट नहीं, कहीं कोई पेन नहीं, बट पेशेंट को लिंगुअल नर्व इंजरी हो गया. So what must be the I would say etiological factor or reason behind it? The answer would be the lingual nerve basically lies into the lingual pouch or the pocket just below the 8th region. Okay, so what happens is when you take a bite, or you need a properly bite, what happens in the lingual region is you go too deep into the lingual pouch, and this is where the lingual nerve injury basically takes place. I've seen many cases. So basically, you need to make sure that you are into the 3-4 mm distance of the soft tissue, and you do not take deep bite into the lingual side. It basically avoid the lingual nerve injury. So basically, you need to take care that of the prevention of the lingual nerve injury, right? Though it is very, I would say, temporary maneuver, but I have seen many cases, including mine, I won't say, that the lingual nerve injury exists, and the permanent injury measure is higher in comparison to the, I would say, inferior alveolar nerve injury, right? So in such scenario, you need to be very careful regarding the inferior alveolar nerve injury, which you have seen. You can avoid it by proper maneuvering, removing the distobuccal margin, dividing the tooth into proper halves, and delivering the tooth with minimal pressure, right? In cases of lingual nerve injury, you need to give proper local anesthesia. Do not go into the lingual pouch while you are using your micromotor or your physio dispenser. Do not do suture without paying much attention to details into the lingual pouch. Okay, so these are the things. Okay, now I would go a little faster. That these are some representative cases. You will find it little interesting, as we have discussed in the third molar webinar. Okay, there was an extraction case. The patient has reported to me. The age is 70-year-old male, and so in such scenario, patient was being referred to me after 3 to 4, I would say, dentist, and it has been told that all tooth need to be removed and it cannot be properly planned. So what we did is we basically planned it in such a manner, if at all we can remove the third molar and we can retract it orthodontically. Let us see where we have reached. We plan it, we take a proper photograph, took the patient under GA, okay, and we open it the flap. Now you can understand this is how it is done, and we make sure that we preserve the distal bone just beneath the 7, just distal to 7, okay, just so. But the only problem is when we remove the 8, we basically, I'm just telling you that you need to remove the distal bone, right? But in such scenario, I need to preserve the distal bone just beneath the 7, so that I can upright the 7, upright the 6, upright the the premolar also. Okay, so I need to preserve that distal bone. So I use a specific instrument known as piezotome that cuts the bone in a specified manner. Now you can see it here. We remove the bone. We remove the tooth along with the preservation of the distal margin of the 7. Now you can see it here. This is the bone which we are talking about. This is the distal margin of the bone, and we basically put a mini plates at the external oblique ridge and band it in a manner that it pops out of the soft tissue socket, and we put a button over there. Okay, just to upright the Litowa 7, upright the horizontally impacted 7, right? Now this is the position where we are. What we did is we uprighted the 7, and the moment we found that now you can see it here. This is the E, which we can see. Now we need to remove the E, and at the same point of time, we need to apply the 7. What we did is we removed the E portion, E tooth, and at the same point of time, we made a ditch. We made a corticotomy cut at the premolar so that it can also be uprighted on its own as much as it can. Okay. Obviously, it was at the lower border. We cannot put our bracket there. Okay, but what we did is after some point of time, it erupted on its own, and at the same point of time, the 7 has come out from its original position, and 6 is still in the mesangular position, right? So this is the place where it was in the initial position, and this is now it is, and mostly now we have put a socket there on the premolar position, and we have removed the buccal plate. We have removed the mini plates. Okay. Now, transplanting third molar, in the third molar region, what we need to do is whenever there is a curious tooth, what you can do is we can remove the third molar as per our convenience. If we found it suitable, you can put it in the places of 6. Okay, rather than implant, let us do a auto transplant. Right, minimal damage during transplantation. It increases goal of pedial cell of donor teeth. Many time patient is not paying, but we still feel like कि एक teeth बच सकता है, उस wisdom teeth का कोई role नहीं है. We try to put it into the natural position, right? So mostly अगर आप normal teeth से करोगे तो बाकी you need to be very much careful of the distal bone which you are discussing, of the PDL also. You need to be very careful. You need to preserve the PDL. Okay, this is how it is. It is a mirror image of the upper 6, and now this is here, and we try to remove one tooth, and third molar we removed it. We removed the I would say 6 with the intact. I would say with the intact margins interradicular septum, right? And now what we did is we removed from the distal buccal margin to the distal lingual margin with the help of J2, and after that what we did is we properly and slowly luxated without touching the PDL fiber with minimal trauma to it, and this is how it is there. We suture it up and tell patient not to take any food for a month, and this is how it is. Post-operative 1 month, 1 year, sorry. And there was no mobility as well as there was no periodontal pocket, right? And when we took an IOPA, we found that a proper laminar dura and tibial space on the radiograph post-operative 1 year was noted, right? This is how it was. And now there was another case that was attempted by 3 of the dentists where the upper third molar was dislodged into the pterygomandibular fossa. Upper molar नीचे mandibular fossa में जाके अटक गया, and this is the cases where it was presented to us that how we need to attempt it. Okay, so what we did is we get a scan done, and there's a software called Mimics. We did a proper scanning, know the proper positioning of the tooth where it is. Okay, and where it needs to be removed, and the only problem is the inferior nerve there. Okay, and we at the same point of time we don't want to injure the spinomandibular ligament, which is just, I would say, distal to the, which is just near to the posterior border of the mandible, right? So what we did is we properly make an incision just like we did in orthodontic surgery, and we remove it with the help of a Cocker's forceps. Okay, this is how it looks like, and this is the post-operative radiograph of the same, post-operative OPG of the same, right? So, and this is the case which we have, I would say, published, so that other guys, other crowd can learn from it how it can be removed, and this is the case, right? Now one another case, the last case. There's one 7-year-old patient that was referred to us at the first permanent molar was missing on left side. everything was fine in the remaining dentition. There's nothing that can be ascertained. And but the only issue is the patient was of 7-year-old. Okay, so we need to take care that despite 7-year-old, why the first permanent molar hasn't come. So what we did is we advised the OPG for the same, right? When we did an OPG, we found compound odontome lesion. So there was a impacted tooth, and there was no 7 and 8. Okay, no 7 and 8, unlike all the other area, but there. Okay, so missing 3, 7 and 3, right? So what we did is we took a stand and there we found the expanded buccal plate there. Okay, and with only now you can see here the lingual margin, inferior nerve, which is there, and the lower border continuity is also there. So the plan would be either हम पूरा mandible काट दें, okay, lesion को और placement और उस पर graft कर दें. But age जो है patient का 7 year है, female patient है. We all know that how females are being considered, if at all they have a lesion, they have a I would say scar mark on face. So we need to be very much careful that this treatment plan should be very much negative, right? So on treatment plan 2 would be उसको plate उतना mandible intraorally cut करके हम mini plate या reconstruction plate लगा रहे हैं. But if at all we see that considering the advancement which we have received in the recent coming years from you guys can also appreciate that from I would say dipping developer to an RVG which take multiple X-rays in a span of 2-3 minutes, you can also know that there is an advancement in the surgical tools as well. If at all we can preserve the lingual and lower border, nothing like it, we can preserve it, right? So what we did is we follow the treatment plan, we preserve the buccal flap, we do not raise from it, we create a lateral window with a piezotomy, and when you use a piezotomy, and after that when you completely remove it, and you do not raise the flap till the lower border. Obviously when we know the periosteum obviously is very much required to preserve the bone vascularity. So what we did is we create a lateral window, we remove the tooth, and we put a PRF there. Okay, we put a PRF there. We basically avoid graft because obviously patient was a little I would say, and the graft was in would have been in direct continuation with the inferior alveolar nerve. So this is how it looks like, the PRF in the cavity it looks like, and this is how the tooth which we removed, and number of people was 202, and we properly divided the tooth. Now you can see it here. I will take you to the preoperative OPG of the same patient so that you can understand why we divided it with the help of a piezotomy. Okay, now you can appreciate it here. Okay, if at all we have removed it, it would have fractured the mandible. So what we did is we divide the tooth from the crown portion and divide the roots in the half, in the 2 halves, and we removed it in 3 separate halves, right? This is how you can appreciate it here, and we were able to preserve the bone. And after 3 months, you can appreciate here the lamellar bone formation was already happening, and the woven bone formation at the distal margin. So this at all we are able to preserve it. We tell the patient that not to have any food from the left side, right? So for that we covered, we got coverage in the press also, and for that, and where we remove the tooth from the 7-year-old child. Okay, so let us come. We have come to an end of our webinar. Okay, where you can see and understand. You can ask a query at the end of the webinar. Okay, with my AIMS colleague, we are also doing a startup. I would say I would happily announcing it in front of you. Basically, what we did a study among 250 dentists, that some pain points for dentists are they basically do not get enough patient for their clinic, right? They do not get digital presence. Obviously, in an era like this, in a ever-changing era where digital presence is more important than the I would say physical self. अगर किसी ने गलत Google review डाल दिया तो we basically got irritated for no reason. Okay, so what we understood that dentists being non-technical and from non-IT background, पेशेंट लीड नहीं आते बिकॉज देयर डिजिटल प्रेजेंस नहीं है, मार्केटिंग नहीं है, पेशेंट एजुकेशन मटेरियल प्रॉपर्ली वो डिलीवर नहीं कर पाते टू देयर एग्जिस्टिंग पेशेंट्स. ओके, मोस्टली यू डू अ वेरी गुड रूट कैनाल, बट पेशेंट ने वहां पर बाइट नहीं कराया या कैप कराने नहीं आया. सो व्हाट वी अंडरस्टूड इज these are the pain points for dentists that will help them to get new patient, to give more value to their existing patient. And obviously patient record is very much important, which you've understood. So for that, what we did is we made a platform that allow the dentist to make a website come web page in 10 minutes. Obviously it's in the initial stages, and we have been accredited from Startup India, and we have been getting training from IIM, and God has been fortunate on us to give us such good platform like IIMS and IIM. And so basically the value and benefits to doctors are, it's a maintenance free web page as website. Okay, when you go to a website developer, either वो बना देगा, बनाने के बाद वो 20,000 25,000 मांगेगा, नहीं तो कम बना देगा, आपको खुद मेंटेन करना पड़ेगा, और after 1 year or so you will go away, your website will turn off. Okay, or you have to shift to one platform that would charge you per patient. Likewise, the Practo or just that, they will take you per patient per call, they will charge. So what we have done is we will charge from the dentist on a yearly basis, but not now. After we will get some patient, we will get our platform properly devised. You can put your WhatsApp button directly on your web page, and so that you patient can communicate to you directly. Okay, you can upload your clinical cases, you can show your skill directly to the patient, because many a time we cannot showcase our skill to the patient. तो पूछता है आके कि आपने करा हुआ है. If at all you can showcase yourself other than the existing platform like WhatsApp or Google page, you can obviously show them. Patient can reach through you through Google Map, and you can patient can also put their Google review, right? And the other things which you can see it here would be patient lead form. Patient can generate query, and you can get a query there. If at all you want to see it here. Okay, and this will increase your market presence, right? So this is the name of the website, and I would rather forward the details to Dr. Sudhir also, so that they can also forward it to you, or otherwise you guys can take a screenshot of the same, and you can help us. You can help us not by paying, but I would say by joining the platform. Obviously, it is for you, for dentists, from the dentist, and we basically have a good intention to basically help dentists to get good revenue, good generation skill. And it is a saying in startup culture, if at all you can help someone to get a good revenue, it is also a service. Okay, so we digitalize dentists, and in case if you guys have any query or issue, you can give me a contact, not regarding the my dental, but also if at all you have any query regarding any surgical procedure, or I would say maxillofacial cases, you can give me a call on this number. Okay, this is my number, and I would hand over to Dr. Sudhir for allowing me a great opportunity. And you guys can write in the chat box koi bhi query or koi question hai, you can ask. Obviously we all are learning, and this learning obviously is much beyond this universe. In fact, kabhi bhi learning ka end nahi hai, there's infinity and beyond. You can also give me a feedback to learn one thing or the other in the chat box, or you can send me in the personal number.
ओहो, ये क्या हो गया?
Yes, Dr. Ankur. Dr. Sudhir, are you there?
Yeah. Okay, so you concluded?
Yes.
Okay, sir. Thank you so much for a wonderful session. It was a step-by-step guide and easy to understand how to go about it. The only thing remaining is, I think, hands-on, or doing it on your own patients, all you dentists here. So can you all please come on the video so we can have a picture of all of your beautiful faces with the guest speaker today, as well as after that, after I take the picture, you all can ask question and directly talk to guest speaker Dr. Ankur Arora one-on-one, and we can have an interaction. We have few questions. After your questions, I will ask those questions. I have only two to three questions which were asked by some dentists previously. So if anyone wants to ask question, go ahead. It's all yours. Go ahead. Yes, Dr. Hemant. Yeah, go ahead.
Yes, Dr. Hemant. I think you are on mute.
Dr. Hemant, you raise your hand, unmute yourself and ask your question. Dear sir, there is a question in the chat box.
Okay.
Please me again. He means to say, I think the burr in the burr for extraction.
Okay. So the burr is you can write it down, the carbide burr, and basically the burrs that are used are 703 and 702. Okay, 703 and 702 burr, straight hand piece.
Fine. So next question is, how do we go ahead for a badly carious tooth when it is difficult to get the grip? Forceps में grip नहीं आता है ना, so how do we go about it?
So basically, many a times if you see you are extracting 6, you are extracting 5, you can extracting 4, but badly carious hai, and you are not getting a fulcrum, right? So in that scenario, my advice is treat it as an impacted case. Treated as an impacted case, you need to down the fulcrum from the bone to the tooth. Okay, the tooth is beneath the bone, and you cannot take a grip. You cannot take a grip on with the help of forceps. Obviously, the tooth is below the bone. So in that scenario, you need to lower down the buccal bone level. You can lower down the buccal bone level in a scenarios where your fulcrum can be used again. You can apply your elevators. You can luxate it slightly. Make sure you do not luxate the adjacent tooth. The moment it is luxated, either you can use a forceps or you can deliver it with the help of your luxators.
Thank you, sir. Anyone has question?
There's a question from Dr. Dhaval Shah, who said how we can create a purchase point and where. Okay, in
Yes.
cases of wisdom teeth, you can create a purchase point just below the CEJ, that is 2 to 3 mm below the CEJ, or if at all it is impacted tooth, you can go below the circumferential area, right? You can below the circumferential area, the maximum circumference. Okay, and at the same point of time, it's a misnomer. It's a, I would say, misconception among the dentists that a fulcrum need to be fixed at one point. अगर आप टूथ निकाल रहे हो, टूथ निकालने के साथ साथ पोजीशन पे टूथ भी हिल रहा है. Okay, you can change your fulcrum to a deeper position. अगर आप कोई चीज निकाल रहे हो, आपका टूथ हल्का सा हिल गया, you can go further deep and you can use that fulcrum. Okay, so there's a, I would say, there's a dynamic position of fulcrum. There's a dynamic position of fulcrum for impacted teeth just below the tooth or 2 to 3 mm below the CJ. Okay, or if you want to see that video again, you will be able to understand. I have in that video, I have been told that you need to make a proper video. So I made. You want to see it again? You just drop me a personal message. I'll send you that video. Okay.
Fine. Thank you again. Already you covered in your session in your PPT about dry socket. Dr. Hemant wants to know about dry socket once again. If you can repeat.
Okay. Sir, give me repeat details for dry socket. Okay, so basically, I would say the first and the foremost advantage, would say instruction to get the dry socket is to prevent it. Never let it happen. और जैसे पहले बताया, बोन जब भी इन्वायरमेंट में, जब भी ओरल कैविटी में एक्सपोज होगा, ड्राई सॉकेट होगा. So for that you need a proper compression, give a proper head gauge, okay, or proper suturing. I have basically made a protocol. Even if it is a single root tooth, always give a suture, because you never know which patient is going to smoke, which female patient is going to drink tea more. So in such scenario, blood clot is about to release and it will about to give a nightmare. Okay, so in that scenario, first answer would be to prevent it. Second, if at all it happens, you need to cover it. cover it either with the help of a urinal dressing, right? Either with the help of a alveolar dressing or either with a simple normal saline dressing. You need to gently irrigate the tissue, remove the slough out, and remove the debris and the soft tissue out. Gently massage the bone with the help of a saline dressing and allow it to heal with the help of antibiotics and analgesics. And basically, if at all pain is there, it will slowly and gradually subside in a period of 5 to 7 days, right?
Okay, thank you again. Which suture material is good and which company you suggest?
Basically, it's upon the preference choices. I use 30 silk, 30 white rail. You can write it down true silk if at all you wanted to use. It's basically or ethicon or lotus. There are many basically, but obviously since the PM Modi has given us the instruction to use made in India instrument, so basically we go for a lotus surgical procedure or a true silk. It's up to you. Otherwise, ethicon suture, they are the gold standard. But nevertheless, these sutures are also giving good competition to this international market.
Okay, thank you. How do we elevate such a tooth? So, I mean, she must be asking tips.
Fulcrum position. Okay. Okay. So, I'll send the video to Dr. Sudhir. He can share it in a group. Okay, in a group. Okay.
Fine. I'll upload it on YouTube channel by on your name with courtesy to you.
No issue. No issue.
Share the link to each and everyone. Dear sir, give me repeat. Okay, dry socket is covered. Sir, how much average you charge for this?
Let it be. So basically,
okay.
let it be. So
Yeah.
depending upon the feasibility.
Yeah, I'll go to next question, sir. How to manage inferior alveolar nerve or lingual nerve injury?
We have already discussed in inferior alveolar nerve, divide the tooth. If you divide it, there are less chances. There are less chances of going to the nerve. Okay, as I've already told you, bone and nerve belong to the patient, tooth to the surgeon. Play with the tooth to prevent the bone and the nerve. Okay, and lingual nerve injury, you need to suture it in a proper manner. Okay, and other than that, nerve injury, mostly God is very kind to us. Mostly 95-97% of the cases, they resolve on its own after 6 to 8 months period down the line. Okay.
If more details you want, you can go back to the video, which will be uploaded on YouTube, and you can check the details. The same question. Sir has already explained. Sir, next question is if root tip breaks, how to decide if it is safe or let it live in the socket?
Okay, how to see if the root socket is less than 2 mm, you can leave it, or it is in the near the sinus, you can leave it, and otherwise you try to remove it. Okay, basically there is also I don't know you guys know it or not, there's a buccal shield technique. Okay, buccal shield technique where the implant is being placed just adjacent to the tooth. Okay, तो ऐसा नहीं है, इम्प्लांट भी ऑस्टिंटिग्रेट हो जाता है रूट के साथ. तो और अगर रूट भी दे दोगे तो what basically happens in due course of time, nature try to push it up in the mucosa and you call it root stump after few years. Okay, and you call it. So basically अगर रह जाती है, need not to panic, but my instruction is you need to inform the patient. Okay, what happens is in due course of time, whenever patient goes here and there, if at all he or she finds a root there, they tend to be a bad word of mouth for you. Okay.
Okay, thank you again. Next question, management of accidental displacement of tooth root in spaces. She
so for that, in case you are removing, so basically I am of the opinion the easiest tooth to remove in the oral cavity is upper third molar. At the same point of time, I would say the maximum complication that a dentist can have with a tooth extraction is the upper third molar. It would either go into the sinus spaces, that is the maxillary sinus, be it the first molar, second molar, or the third molar, or it might go into the pterygomandibular space, which you have already seen in the case which I have shown it to you. Okay, so in such cases, if at all it happens, in case the lower molar, it goes into the lingual pouch. So what you need to do is, first of all, you need not to panic. You need to take proper IOPA, okay, and get an proper OPG, that orthopentomogram done, so that you get a proper 3D presentation where the tooth root is, okay, and then you can call upon the specialist. Need not to shy, okay, need not to shy कि मैं निकालूंगा वो क्या बोलेगा कैसे करेगा. Many cases they are for learning, okay, not for earning. So most of the time we learn, we earn, but if at all it do not happen all the time, need not to panic, need not to shy. You can take a expert consultation, and then you need to decide it as per the call, okay, as per the call. I won't say there's a generalized rule. If at all it is in the sinus, you can remove it. If at all it is in the pterygomandibular space, small 2 mm root, you can leave it. It will fibrose on its own. If it is in the lingual pouch, you need to remove even a single mm of bone, because obviously it can go into the parapharyngeal spaces. So it is according to the cases you can take a call. But yes, basic controllables are you need to take a proper radiographic investigation, call an specialist, and you can obviously plan the case as a new case, right?
Okay, thank you, sir. And apart from questions, there is a lot of appreciation also. Dr. Abhishek is saying very nice session it was. Thank you so much, sir, for answering the questions. Then a few more people are saying that, yeah, very nice session, sir. Wonderful session. So next question is, Zerodol SP is suitable for cellulitis or any swelling with abscess?
Yes, Dr. Sudhir, please believe.
Zerodol SP is suitable for cellulitis and any medication for swelling along with abscess.
Okay, you need to see whenever there is an abscess or swelling, na, you need to understand what is the flora there. What is the flora? Okay, so the question is from Shabana: is Zerodol SP suitable for cellulitis or any swelling with pus? Okay, so you need to cover it up with a gram-positive. Okay, so in that scenario you can add augmentin, which has a clavulanic acid, and at the same point of time, to cover the gram-negative bacteria, you can add metrogel or the flagyl 400 mg BD, and at the same point of time, to decrease the concentration of inflammatory cytokine, you can add enzoflame or Zerodol SP. I'm taking the commercial names, but at the same point of time, you need to have the chymotrypsin or trypsin. Along with that, you can add NSAIDs, and you have to keep it on a long regimen, that is for 5 days, and you can proceed for extraction of any time after 3 days. Okay, 5 days ka antibiotic or painkiller chalega, but after 3 days you can proceed with the procedure. If at all the infection is due to the root canal procedure, you need to open the canal also. Okay.
Okay, so thank you, Dr. Vijay, and few more doctors wants to know if more doubts are there after the webinar is completed. Can we contact you with our questions personally?
I have already forwarded one message to Dr. Sudhir regarding my startup. In that, I have my number also. So
Yeah.
Sort of a promotion only. You can register on my startup as well as it has my number. You can register on that.
So I'll share with you all, each and everyone. 127 registrations were there. With all 127 registrations, I will share all the details. You will get the contact number of guest speaker, Dr. Ankit Arora, sir, today, and you can ask and contact him in future also after the webinar. Sir, next question is, how root tip is infected and how to prevent fracture of maxillary tuberosity while extracting third maxillary molar.
Okay. Let me.
So below the previous question, just below the previous question.
Okay, how to prevent fracture of maxillary tuberosity while extracting the maxillary third molar. Okay.
Yeah.
So basically, okay, Devangna, right? Devangna, what you need to understand is when you extract the maxillary third molar, you need to understand that most of the time, in say studies have shown that in 12 to 15% of the cases, the maxillary tuberosity is ankylosed to the palatal half of the maxillary third molar. Okay, so 12 to 15% of the cases में ankylosed होती है. जब आप निकालोगे तो फ्रैक्चर होगा ही होगा. बट व्हाट वी प्रेजेंटली फील that why it has fractured and how we need to be removed. So now the recent protocol by BGMS, it says that if you are removing the third molar and it comes out with a piece of maxillary tuberosity not larger than 12 to 15 mm of bone, you need not to replace it. You have to consider this as a portion of the tooth only. अगर दांत निकालते वक्त tuberosity का एक पोर्शन आता है जो 12 mm से बड़ा नहीं है तो उसको दांत ही समझा जाए, उसको ज्यादा पोर्शन नहीं करना है. बट मेक श्योर नो लूज पोर्शन ऑफ tuberosity इज लेफ्ट बिहाइंड इन द सॉकेट. ओके, छोटे दो पोर्शन अगर फ्रैक्चर हो गए, एक पोर्शन लूज पड़ा सॉकेट में, इट विल फर्दर ऐड टू द एगोनी ऑफ द पेशेंट बाय कंटिन्यूअसली इंड्यूसिंग द inflammatory mediator, और फिर से पेन होता रहेगा पेशेंट को. So you need not to leave any loose portion of the bone in the socket. Okay.
Okay, thank you. One question was missed. Dr. Rashmi asked that question. How to give incision for unerupted tooth?
See, you need to understand. Say, I would let me show you one photograph so that you can understand. And one. Now, Dr. Rashmi, can you see the OPG? Okay, this is the unerupted tooth. Now we need to remove the 8, and for that, what we have done is we have given the incision just distal to 7, and along the curvature of the bone that is available, and at the distal lingual margin of the third molar. Right now you can see there. This is the unerupted molar. Right, unerupted molar. This is the 7 which is present here. And for that, what we need to give is I have given the incision in this manner. Now you can see it here, just distal buccal margin along the curvature here and along the distal lingual margin. Right, this is how it would be. Just beneath this would be the 8 which is present. Okay, now you can see it here. This is how it looks like. Now is it clear, Dr. Rashmi?
Yes, sir.
Clear, sir. Clear.
Okay.
Almost we have covered each and every question. So many questions were there. So lots of participation was also there. So many people registered. 127 people registered. Anyone has any question? You can go ahead so that we can conclude today's session. Any question is there, you can ask now in chat box. You can ask directly to Dr. Ankit, or you can directly contact him. We will be providing you contact number. One doctor is asking that I missed the session or I was late to join. Don't worry, you can attend this session on YouTube. The only thing is you will not be able to interact with the mentor directly. So make sure next time you attend the session whenever we start it, so you can interact with the mentor directly one-to-one. This session you can attend on YouTube. Don't worry. Previous sessions are also there. This was 7th webinar and online 152nd online session. So you can attend 7 webinars are there on YouTube channel. And in future also we will be posting it on YouTube channel. As well as Dr. Ankit said, his initiative you can join. I'll send you details to each and every one. Anything else is there? Let us know, or else we can conclude the session. Yes, sir. You want to share anything?
I already shared the details.
It was a nice session.
Someone has asked me.
Yeah.
Okay. Okay, and at the end, I would say a huge, I would say, thanks to Dr. Sudhir. Many a time we miss I would say, background efforts of the people who is doing that. And I've already told everyone in the starting of the session that if you help Taiwan, you help the nation. Okay, so that makes a difference between a developing and a developed nation. Let us help each other by helping out. Okay, still I would say, Dr. Sudhir, you should keep doing the procedure, and I would say giving me the opportunity to share my experience with you all guys.
Pleasure, sir. Pleasure here to each and every one of us, and it's all teamwork of dentists, mentors, and everyone. To have such wonderful speakers like you, and you in 1 second you accepted the invitation. Thank you so much for that. We would like to have you one more time in future. I'll just have suggestions from the dentists, what they want to know now, what they want to learn apart from Disimpaction. I'll organize one more session with you, and it will be a pleasure having you once more. And the huge response for you. I think 127 registrations were there. All of them, I think, will join your initiative also. Okay. If any course and anything is there, hands-on, you let them know so they can join. Even we will be having through our academy hands-on course Disimpaction. We will send you details onwards. Anyway, so thank you so much for this wonderful afternoon. Take care. Have a nice day. We are ending this session. I'll end the meeting, sir. Okay. Okay. Thank you. Have a nice day, everyone. Bye. See you in the next webinar.
Okay.